Thank you. So I'm going to talk about some of the current ideas within clinical trials for GI malignancies, specifically for colorectal cancer. And again, just as a reminder of while we're doing the clinical trials, we can certainly reflect on the advances that we've seen from chemotherapy, and now that standard therapies extend survival to more than 29 months is very reassuring that chemotherapy does provide substantial benefit to our patients. This is from the 80405 updated numbers. We've also learned and seen throughout the day that regorafenib and TAS-102, while have the ability to provide benefit, this is modest benefit, and novel treatments are very much needed. So for the next 20 minutes, we're going to talk about what some of those emerging therapies are. The first three ideas that I want to put out there are just really that. They're ideas, they're early. We'll see where they get to. And then I'm going to spend the last 10 minutes talking about bispecific antibodies, which are also currently in the clinical trials. So patients ask about CAR T-cells. We know that CAR T-cells are very effective in hematologic cancers. Have these been tried in colorectal cancer? And what did that show? So there was a study of a CAR T-cell done. This contained a retrovirus encoding the high avidity murine CA receptive T-cell receptor. And this was given to 3 patients in an early study with metastatic colorectal cancer. And what we saw here is that there was a tumor shrinkage, that tumors came down, and here you can see on the CAT scans the clear regression in metastases. So the idea that CAR T-cells could lead to immune responses within colorectal cancer was clinically reassuring. However, this was at the expense of toxicities, and these patients developed a transient, albeit severe, inflammatory colitis, which was a dose-limiting toxicity in this clinical trial. This occurred in all 3 patients, and these patients were neutropenic, and GI infections were ruled out, showing that as we develop CAR T-cells, there's still a lot of work to be done, potential for efficacy, but we have to figure out how to do these. The next concept, similar to the last, but not modified T-cells, rather taking tumor-infiltrating lymphocytes, has also been extensively studied, and this has been done for a long time within melanoma. So these adoptive cell therapies really use ex vivo expanded tumor-infiltrating lymphocytes, and in melanoma can lead to cases of durable clinical responses. And perhaps this is mediated by T-cells that target the neoepitopes. So a small trial is being done. This is an immunotherapy using tumor-infiltrating lymphocytes for patients with metastatic cancer. And what this study did show us that in one particular patient with colorectal cancer had a mutation in the KRAS G12D, and T-cells against G12D led to a marked clinical benefit. With adoptive cell therapies, patients undergo a myeloablative chemotherapy regimen to make space for the T-cells. Following that, the T-cells were transferred back into this patient. Patient had 7 lung lesions that regressed early at the first follow-up visit, which was 40 days thereafter. And here you can see the regression, for example, here in some of these metastases, and ongoing a 9-month partial response. What determined the end of that partial response was the emergence of an escaped lesion that you can see developing here on the 3rd CT scan. This was resected, as is appropriate in immunotherapy for escaped lesions, but there was response in the others. So against the idea that tumor-infiltrating lymphocytes against G12D did lead to a clinical response, and this is an ongoing study. The third idea that I'm going to talk about is radiation therapy, and this has been discussed for a long time and will be discussed a long time going forward, and exactly how this fits into immunotherapy is still to be determined. The observation, and this was published by my colleague Mark Pasta in a patient with melanoma, that led to the reemergence of this idea of an abscopal effect was in a patient here who was treated with CTLA-4 blockade with ipilimumab. And this patient had multiple metastases. Here you can see a pleural-based met. Here you see mediastinal mets, and then liver metastases. At the time that there was disease progression, this patient became symptomatic and underwent radiation therapy at this point. Following the radiation therapy, there was growth in the tumor lesions, but markedly, at the same time that the radiation had its effect, there was regression in other tumors as well. This was not considered to be a delayed response from ipilimumab, given the amount of time the patient had been on ipi up until this point, and also based on the correlative studies that showed a change in the immune milieu within the peripheral blood cells that showed that there was more of an immune response with suppressive cells going down and active cells coming up. So this was thought to be real and led to many other clinical trials looking at this within different tumors. So within colon cancer, we did this trial looking at pembrolizumab with either radiation or with ablation. So pembrolizumab, right, PD-1 blocker. And the primary objective there was a response rate in the non-radiated lesion, and patients were eligible for this study if they had a lesion that was appropriate for standard palliative radiation or ablation. And here we did the radiation ablation within 1 week prior to the pembrolizumab based on mouse data showing that there should be, at the most, a 1 week difference. Whether you start with radiation ablation or with PD-1 is still unclear, but they shouldn't be more than a week apart. It was a Simon two-stage design, enrolled 9 patients. If we see a response, we would enroll more. They had and have measurable disease, and they all underwent the modality as discussed. What we did observe in this trial, so we completed the radiation arm. We enrolled up to 21 patients at the time that this was reported. So it expanded because there was a response. The ablation arm had no responders, so we stopped at 9 patients. We saw the expected toxicities that we would expect from pembrolizumab, fatigue, pruritus, rash, dry skin. There was diarrhea, nausea, dry mouth. All what we see in our patients undergoing PD-1 blockers, we didn't see any added toxicity from the combination of radiation. We did observe a response. So this is anecdotal, right? One patient responded, other patients had stable disease. There were some mixed responses. So to be clear, this was a negative study. This did not show that there was a benefit from this combination, but perhaps we could learn from this. A patient that did have this abscopal response had a retroperitoneal lymph node radiated. This was causing a symptom. And the patient still had a lot of disease elsewhere, so an internal mammary node, pleural effusion, and pleural-based Mets at baseline. And from June to November, patient had marked regression in all these different lesions, and this was an ongoing response. Patient had this ongoing response for a very long time. In addition to that, there were 2 patients that had a mixed response. So this was one patient who had radiation to a liver, and on the follow-up scan showed a lung met, which was very clearly outside of the radiation field that had gotten smaller. There was another patient that had radiation to the left hilum and had a right-sided lung met that got smaller. Other lesions got bigger, some got smaller. This is not what we see in our patients with colon cancer that have chemotherapy. These types of mixed responses are rare, but here we see it in 2 additional patients. So perhaps there's something going on. We have taken this further to another clinical trial with anti-PD-1 plus anti-CTLA-4 with durvalumab and tremelimumab, which is an ongoing clinical study recently started. So those are ideas, and I think we'll see how those are going to fall within colon cancer. And I'm going to now spend the rest of the next 10 minutes or so talking about these bispecific antibodies. Tony had mentioned that this can occur, and Scott showed an idea of where there may be a specific place for this within CMS classification, although the studies now are being done in all patients. So what is a bispecific antibody, and where are they really going to fit? So I'm going to start off by talking about the specific bispecific, and then I'll talk about some of the others to show how they differ. So this TCB, which is in clinical trials, has 2 variable regions here, one there and one here. So it's a very novel 2-to-1 format. And this is against CA on the tumor. And then there's one place where CD3 binds. And there's a hinge here. So what happens is that this arm will flip over, almost like a staple, and it will stick onto the tumor. It's very specific for CA that is membrane bound. It does not bind to circulating CA, and the density required for binding matches what's found in the tumor and should not bind to normal cells outside of the tumor. So this should be fairly specific tumor binding against membrane bound CA, and also to CD3, which is ubiquitous on CD4 and CD8 T cells. So that's the one type of bispecific that we are doing in colon cancer. How does this compare to some of the other bispecifics? So you may have heard of blinatumomab, a drug that's used for the treatment of leukemia. In the next 2 slides, I'll talk a little bit more about that. because at least it shows us this kind of technology can work. Here, blinatumomab is a much smaller molecule. It's just the variable regions that are attached to each other. Hence, it's given over a prolonged infusion because of the very short half-life. And there are other similar drugs that are in clinical trials, for example, one that binds to p-cadherin and CD3, the DART molecule, that's in other trials. The one in the middle is the one that I'm going to talk about for the next few minutes. So before I get there, there's the BiTE, the one that binds to CD19 on leukemia cells and T cells, leads to targeted killing of the leukemia cells, and this is an effective therapy. Initial studies showed in 185 patients with refractory relapsed leukemia, there was a 32% CR rate just after a few cycles of treatment, and the response was durable. So this is a therapy that's used for leukemia patients. We are now trying to bring this into solid tumors, specifically colorectal cancer. So how do these work? So this bispecific antibody is going to attach right to the tumor and then to T cells. Now, those T cells could be any type of T cell. They may be the tumor-infiltrating lymphocytes that you saw on Scott's previous slides, the ones that may be resident within the tumor or around the tumor. So if there's some tumor specificity, those T cells could become activated. They may be tumor-specific T cells that are moving through the tumor, but otherwise wouldn't stay there, but they get latched on by this bispecific. Or they could be non-specific T cells, such as a flu T cell that's just moving around the body, but gets stuck by this bispecific, right? Now, T cells' job is to move around the body and find things that are different, right? Usually viruses and infections, occasionally tumors. And T cells do not like to be stuck. They don't like to be tethered. As soon as they are tethered by these bispecific antibodies, these T cells get angry. They start to kill whatever is closest to them. They latch onto the target. They form an immunological synapse, and they'll send their little warriors inside there, the cytotoxic granules, to kill the T cell that's there. In addition, they'll start to secrete a lot of cytokines that will recruit other T cells, leading to a secondary inflammatory response, and ultimately they might also include a tumor-specific T cell response. After the T cell does killing on one tumor cell, it can then latch off and it can move somewhere else. So these T cells are mobile, and there's serial killing of this. And again, most importantly, it's independent of specificity. So those T cells don't have to see an MHC class 1 for their initial binding. So a very well thought out preclinical idea. When this was looked at in a preclinical murine model, what you can see here is days after the mice were inoculated, the size of the tumor, and in uncontrolled or untreated mice, tumors would grow. If you gave these mice an anti-PD-L1 by itself, there was no regression. If you give them this bispecific antibody by itself, there was some effect. And if you combined the bispecific antibody with an anti-PD-L1, there was even more of an effect. You heard in the last talk about this gamma interferon. So if you have a T cell that's stuck in the tumor, and that T cell is starting to secrete gamma interferon, the tumor will upregulate PD-L1, and we need to quell that secondary PD-L1 upregulation. So the idea of adding an anti-PD-L1 there is to prevent secondary resistance from occurring. This has led to 2 ongoing clinical trials evaluating the TCB by itself, as well as the TCB in combination with atezolizumab. And there's a good chance that you may be referring or putting your patients onto one of these trials. These trials are ongoing. They're getting to be large clinical trials. And if you ever have any questions about these, please feel free to reach out at any point. In the monotherapy study, this is a dose escalation study, initially single cohorts and then multiple doses in escalation. And in the combination study, it started at multiple groups with a dose escalation of the CA-TCB with a set dose of atezolizumab at 1,200 every 3 weeks, which is the standard dose. One of the phenomenon that we've learned about this type of a strategy is that because the T cells get stuck in the tumor, they release these cytokines, there's this idea of an inflammatory response. So there's a cytokine response with cytokine release type syndromes, as well as marked inflammation of the tumor due to these cells getting stuck there. And this can really begin within hours. And these are 2 patients that had scans done because of symptoms. So and again, these are microcellite stable. These are all MSS patients. I'm not talking about MSI-high patients. And here you can see within 48 hours, a small lung met had flared up. And several of these lung mets flared up within 48 hours after initial treatment. And here is a patient from the combination therapy of the bispecific antibody plus atezolizumab that had an increase in liver metastases, which can be seen much more clearly. So this inflammatory event can begin fairly soon, but it's transient and should and usually gets better within hours, if not days. But good proof of principle of the mechanisms that we are trying to achieve. The types of side effects that are observed here are related to the inflammation. The inflammation can cause discomfort, for example, or LFTs can go up, depending on where the tumor is, and then there can be the cytokine release. And cytokine release syndromes manifest as fevers, infusion-related reactions, sore throats, chills, rigors. Patients can develop diarrhea. The rate of grade 3, here you can see this is the monotherapy study, this is the combination therapy study, that the rate of grade 3 diarrhea in the monotherapy is 7%, and that goes up to 18% in the combination therapy. Also to mention, a lot of these toxicities are generally in the beginning of the therapy. With subsequent doses, they get better. So patients are not having grade 3 diarrhea for the duration of the therapy. That's an early treatment phenomenon. And then there's the later side effects that can be attributed to the atezolizumab. And there were several DLTs that have also been observed on the study, which are guiding our selection of dose. In terms of how well these therapies work, so this data was presented at ASCO last year, and then we updated it at ESMO in September, and this is the data coming from those presentations. And in microsatellite stable colon cancer patients treated with the monotherapy, this is a small subset of patients. We're just talking about a few. Since then, probably more than 200 patients have been treated, if not a higher number. So the partial response from the monotherapy was 6%, and in the combination therapy, this was an 18% partial response rate, with another 64% of patients having stable disease, and this is stable disease with some tumor staying the same size, some minor regression. This is not stable disease from slow growth, with an overall disease control rate of 82%. So what we have learned from here is that there still is potential for this to work in patients. This is a nice number if this is going to bear out, and there's added benefit from the combination therapy. This is an image which you saw earlier. This is a patient that I treated with microsatellite stable colon cancer, and here you can see a marked regression in a week 4 PET scan with these lung mets markedly reducing, and here you can see on the CAT scan, albeit at a later stage. This is just the timing of the PET and the CT scan is different per protocol, but marked regression there. So in conclusion, what we have learned so far is that colorectal cancer certainly may be targeted by an augmented immune response with clinical benefit in a subset of patients, whether it be what you've seen now in this clinical trial, the other combination studies you heard about earlier with the MEK inhibition, and again, the small number of responses with other strategies that were shown earlier. And it's becoming very clear that there are 2 identified immune subsets of colon cancer according to the microsatellite status, and the MSI high, as you know, are very highly immune responsive, and the microsatellite stable, for reasons of biology, aside from tumor mutation burden, are immune resistant so far. And we need to identify these factors and learn to overcome them. Going forward, there are emerging, novel, and compelling strategies for colon cancer being investigated in clinical trials, and these include checkpoint blockade and combinations thereof, these bispecific antibodies, MAP kinase modulation, and various strategies to otherwise modulate the immune response. Thank you.
Perfect.